Thanks. Yeah, so thanks very much, Kathy, and thanks for the invite for Tom and I to speak at the webinar today. For those that we haven't met, Tom and I, as Kathy mentioned, are both senior health data scientists for the BHF Data Science Centre, and we lead the data management and curation work across the TREs with the aim of accelerating research projects. Our talk today is on constructing research-ready data sets, informing and developing data curation pipelines. I'll just start by giving a quick outline of what we want to cover in this webinar. So I'll start by describing some work that we are doing in collaboration with the NHS Digital Data Wrangler team to update and improve the existing dataset documentation in England. I'll then take a few minutes just to touch on the issue of identifying a population denominator in the NHS Digital TRE. Tom will then do a detailed run through of a data curation pipeline for project CSU 018 in the NHS Digital TRE, and I'll follow this up with a more high-level view of the equivalent pipeline that we've developed for Wales in SAIL. And at the end, I'll also just compare some of the initial outputs that we've obtained from both pipelines. So starting with dataset documentation, currently the main source of documentation for the NHS digital datasets is contained in PDFs in the box folders. For example, here is the PDF for the GDPPR dataset. These PDFs are a really useful resource that contain dataset descriptions, variables and value descriptions, and also metrics based on the actual data, such as record and distinct ID counts, variable completeness, and also the percentage of IDs linked to other key data sets. However, these are difficult to keep up to date in the box folders, and frequently these metrics are out of date and don't reflect the latest data that's in the TRE. Through discussion with the data wranglers, we've agreed to split the documentation into 3 different components. Firstly, an Excel workbook to house all the static information, i.e. dataset descriptions, variable formats and value labels. We find Excel an easier format for searching, filtering and viewing this type of information, and we want this resource to basically look and be an extension of the HES technical output specification workbook shown here. This HES documentation contains dataset descriptions, a list of all the variables, formats and the associated values. And this is what we essentially want to extend across all datasets in the TRE to provide a single comprehensive resource. Secondly, with the data wranglers, we're producing data summary notebooks within the TRE, which will provide all of the updating metrics based on the latest data. So I'll just show now the data summary notebook for the GDPPR dataset. And firstly, many thanks to the Data Wrangler team, in particular Josh Day and Adam Hollings for all their hard work pulling these notebooks together. The notebooks contain batch summaries where you can find record and patient counts and see how these have changed in the latest updates. Also plots showing the data coverage to help with project scoping, and also plots which help with identifying sensor dates for each data set. Finally, variable completeness plots, and again, the linkage metrics to other key data sets. In the data documentation folder now, there are notebooks for GDPPR, HES, APC, and DESS, and the Data Wrangler team will be rolling out these summary notebooks for all data sets in the coming days and weeks. Finally, following on from the summary notebooks, we plan to develop data insight notebooks, which will go a step further than the summary notebooks and provide continually updated set of exploratory data analyses that are specific to each data set. So for example, for GDPPR, we have a plot here showing patient counts by month and by SNOMED code cluster group. Here we can see the amount of historic data that we have for the different code types contained in GDPPR. And for example, we can see that for diagnostic coding, this goes back much further than our medications coding, where coverage really only starts from 2018 onwards. Moving on now to talk about the NHS Digital Population Denominator. This is a topic that's been raised a few times by researchers in various projects. And the issue is essentially how to derive a population cohort from across the datasets in the NHS Digital TRE. The latest available population estimate shows 56 million as at mid-2020, which we compare with 109 million IDs taken from across the sources that make up the skinny patient table in the TRE, specifically GDPPR deaths, and then the HES, APC, outpatients, and A&E datasets. The upset plot shows the total number of distinct IDs in each dataset on the horizontal bars and the total number of IDs in the intersections between the datasets on the vertical bars. From the plot, we can see that the largest group of 35 million is for IDs that are found in GDPPR and all three HES datasets. But the second, third, and fourth largest groups are all IDs found in a single HES dataset only. So this is basically 30 million IDs that appear in one of HES, APC, outpatients, or A&E only. We think this might be to do with how the person ID field in the HES datasets is derived, and this is something we are trying to understand better with help from the Master Person Service at NHS Digital. If we eliminate these groups by anchoring on GDPPR and also exclude deceased individuals, we get down to 61 million IDs, much closer to what we would expect to see. And also this corresponds with the published figures for patients registered at GP practices. This still leaves us with the question of why the 61 million IDs and how this compares to the 56 million population estimate. This is an article available on the Parliament website, which explores the differences between population estimates and GP registers, GP register sizes by local authority. And thanks here to Angela Wood for finding this resource. The analysis shows the local authorities with the biggest positive and negative differences. In terms of positive differences, these are typically areas with student populations and high inward migration, suggesting a systematic undercounting of these in the population estimates. We replicated this analysis in the NHS Digital TRE using the latest population estimates and our GDPPR data, and found a very high level of consistency between our results and those in the article in terms of which local authorities had the largest positive and negative differences. So what are the reasons for the differences between GDPPR and population estimates? So we might potentially expect GDPPR to be less than population estimates for the following reasons. GDPPR only includes 98% of practices. It only includes a subset of records with codes deemed applicable for COVID-19 research. GDPPR excludes type 1 opt-outs, currently around 1 million. And finally, not everyone is registered with a GP. Conversely, GDPPR we might expect to be higher than population estimates, given that GDPPR will include non-residents, those from overseas, students living on borders, and short-term migrants. GDPPR will include so-called ghost patients, those that have died, left the country, moved house without deregistering. There's also potential linkage issues where we have multiple IDs for the same person. And finally, we should appreciate that population estimates may also be underestimates. And it's worth noting that uncertainty in population estimates increases the longer the time since the census that the estimates are based on was taken. In terms of our advice, we would recommend projects to anchor on GDPPR, i.e. include only those IDs that appear in the GDPPR dataset, and to acknowledge and explain the differences between population estimates and GDPPR in any manuscripts. Please also reach out to Tom and myself if you have any questions or would like to discuss this topic. I'll now hand over to Tom, who will talk through the pipeline for project CCU018 in the NHS Digital TRE.
Thanks, John. I'll just start sharing my screen. Can I check you can see my slides?
Yeah.
Great. So my section of the webinar today will last about 20 minutes. So I'm going to provide a detailed walkthrough of the data curation pipeline in the NHS Digital TRE for England on a project that we've been working on. So I hope this will be interesting for experienced users, but particularly helpful for new users starting new projects. So what do we mean by a data curation pipeline? So put simply, it's the process of transforming the collection of raw or original data sets to a research-ready analysis data set that can be used to answer research questions. As Kathy mentioned, it can be one of the most time-consuming parts of a project and will typically include data management, wrangling, cleaning, harmonization, phenotyping, checking, and visualizations. And working across the three trusted research environments where the underlying data differs, the aim is to make the data creation pipelines as similar as possible to produce consistent research-ready data sets to allow the same or almost the same analytical code to be run on each data set. So today, John and I are going to be showcasing our work on the CVD COVID UK Project 18. This project is investigating the impact of COVID-19 infection during pregnancy on cardiovascular maternal health outcomes and on longer-term cardiovascular related diseases. It's led by Elena Rafferty from the University of Cambridge, and it's a multi-nation project with analysis taking place in both the NHS Digital TRE for England and the SAIL Data Bank for Wales. I won't say too much more about the project today because the focus is really on the data curation process using CCU 18 as our main example. So we have the following stages in our data curation pipeline, and I'll keep this on the slides throughout. A similar structure was used to prepare the research-ready analysis data sets for CCU 002 and the studies investigating the risk of thrombotic events following both COVID-19 vaccination and infection. And the code for these projects has formed the basis for the pipelines that John and I have been developing. So one of the most important stages of the data creation pipeline is constructing the code list. This is likely to be used in the cohort selection, the quality assurance, the covariates, the outcomes, and the exposure stages. So here we have the first few dozen rows of a summary of the number of codes in our code list for CCU 18 by name and terminology. The table actually contains more than 50 names, more than 13,000 codes across 4 terminologies containing a mixture of existing and novel code lists. And John and I have started to include data checks, validation, reformatting to ensure the accuracy. I'd just like to mention briefly on a way of working in case it's helpful to others. So typically a project will create a code list based on existing and novel phenotypes. Our preference when undertaking our next multi-nation project will be to have a central and definitive code list which is stored outside of both TREs. Could be saved in an Excel workbook in Box, for example, and this could include code-specific options. So here I mean whether the code should be used to create covariates, outcomes, or both, what data sources should be included if the codes are common to more than one data set. So for example, ICD-10 is common to HES, APC, and DEFs, whether the code should be matched to primary or any diagnostic coding position, what time frame should be considered. For example, current medication covariates generally use a 90-day look-back period. Is there a hierarchical structure that should be applied? For example, can composite covariates and outcomes be created? And all these options could be in machine-readable format and could be picked up by the data curation pipeline to avoid the need to manually set these throughout the notebooks. This central and definitive code list could then be uploaded to the TREs, and any modifications should happen at source, which means this is an iterative process as the code list is updated, possibly due to information from the TREs, for example, STOMED codes available in GDPPR and NHS Digital. And our view is that this would make the process cleaner and easier to follow. Then, as usual, once the analysis is completed, the code list could be uploaded to the BHF Data Science Centre GitHub repository, and any novel phenotypes could be fed back into the phenotype library for others to use. And we welcome thoughts and experiences from others on this at the end of the talk. So at the start of the pipeline, we set our parameters. This includes database names, table paths, production dates to use when extracting data from the archive tables, project start and end dates to define our study population, overall sensor dates. For the latter, this may involve, as Sean showed earlier, plotting the number of individuals over time to see when the data coverage drops off. And it's useful to compare the current year to previous years here. So for deaths, the data coverage looks to be incomplete in December. We can do this for each of our data sources and take our overall sensor date to be the minimum drop-off date, which ensures we have complete data across data sets up to this date. And thank you again to Samit for sharing her work on this. So for CCU 18, we're interested in identifying cohorts of pregnant women from 2019 to present. So we're utilising the HES APC maternity services maternity data set. The number of deliveries have been published online, and these are exactly the numbers that we have available in the CRE. With the lagging data, the most recent financial year, 21-22, is still accruing. I'd like to recommend the HES-APT data dictionary that John showed earlier, the link at the bottom of this slide. Again, this is an excellent resource for field names, descriptions, values, cleaning rules, and it shows that the HES-APT maternity dataset contains almost 100 columns, with 9 fields in this list having 9 columns for the multiple births in a single delivery record. So in terms of how we've used this data to arrive at our cohorts, we began with 1.5 million records, 1.4 million individuals from financial years 2019 to 22. And we began by performing a basic quality control, so removing a small number of duplicates, null records, and data for 2 NHS trusts where the relationship between length of gestation and birth weight appeared suspect. So it did not conform to the usual relationship that we see on the left here. We then performed data cleaning. Our aim was to have a single record for each delivery. So we collapsed records within 28 days and temporarily excluded a small number of individuals with delivery records less than 210 days apart, 210 days being deemed the acceptable interval. And we'll investigate these in more detail when we have time. We then formed our study population, so we filtered by the project start and end dates that were defined in our parameters, anchored on GDPPR for the reasons John mentioned earlier, and restricted to the first delivery. As John will show later, very few records are gained by including second pregnancies in this time study period. And this resulted in 770,000 women, and John will show how this is distributed over time alongside that of sale. So now we've identified our cohort, we can move on to data management. So with reference to the production dates from the archive tables that were defined in our parameters, we can inner join each table to our cohort and save the resulting smaller tables, so-called project-specific data snapshots. So for CCU 18, it's more efficient to refer to these smaller tables, which are used throughout the pipeline. For example, for GDPPR, which originally contained 7.6 billion records, after we joined to our 770,000 cohorts, this results in a data snapshot of 70 million records, so less than 1% of the original. This stage is obviously not applicable to all projects. For example, the population-wide cohorts where all of the data is being used. Data curation, this includes reshaping tables from wide to long format for the purpose of codeless matching. So by way of an example, here we have synthetic data for the HES-APC dataset in wide format. We've got 2 episodes here for the same individual, ICD-10 diagnosis codes with 20 columns for the 3-character version and 20 columns for the 4-character version, which we can reshape to long format. We've also standardized variable names and coding formats, and we're also reshaping the HES-APC operations and deaths dataset to long format. In terms of curating data related to COVID-19, we've utilized the excellent phenotyping work of CCU 13, and we can see that the CCU 13 team have harmonized 7 different data sources to define 10 COVID-19 phenotypes. The CCU 18, we've utilized the positive test, primary care diagnosis, and hospital admission phenotypes. And as in CCU 002, we've separated the hospital admission into those that were diagnosed in the primary and any coding position. Just speaking more generally, the plan is that the data curation stage of the pipeline will no longer exist or be substantially reduced when the curated data layer is established in the NHS Digital TRE, and these reshaped and COVID-19 trajectories tables are available as standard and updated by the data wrangler team each month in line with the batch updates. I'd like to spend a little bit more time talking about the key patient characteristics stage of the pipeline. It's one that we've had a little more time to work on and showcases how we want to approach the data curation more generally going forward. So those working in the NHS Digital TRE will know this as the skinny patient stage. originally developed by Sam Hollings from the Data Wrangler team with Angela and others for the BMJ descriptive paper. The skinny patient tables, they gather together information on sex, month and year of birth and ethnicity from the primary care and hospital episodes to form a single record for each patient. And I believe the term skinny makes reference to the fact that this is a streamlined table, both in terms of the reduction in columns from the original tables and from the many rows to one row per individual. And checking the TRE yesterday, this work or variations of it have been used in more than 25 out of the 30 project directories in the NHS Digital TRE. So it actually involves two stages. The first stage is to produce the unassembled table. So here we're taking the HES, admitted patient care, the outpatients, accident and emergency, GDPPR and deaths tables. We identify the columns of interest for each table and harmonize the data to standardize variable names and formats so that we can concatenate, union or append these data sets together to form a long table. So for CCU 002, this included more than 10 billion records. Secondly, we produced the assembled table. So here we have synthetic data for one individual. We've got 4 records, each being from a different data source. And then we select the most recent record after prioritizing non-missing, non-unknown records and primary care records. So for sex, we select the value associated with the primary care record. For year and month of birth, with no information from primary care, we select the most recent non-missing record. For ethnicity, again, with no information from primary care, we select the most recent non-missing, non-unknown record. So in this extreme example, you can see that we've maximized information with these 3 demographics actually being sourced from different records in different data sources. So these 2 stages they actually form 2 sizable notebooks in Databricks in the data curation pipelines, and are currently being reproduced for each project and sub-project. We've taken a different approach. So we've wrapped these notebooks into functions that can be stored in a common directory, which can then be called in each project and sub-project. And you can see that options have been added to the assembled function to cater for different project needs. So we've got individual sensor dates versus an overall sensor date. We've got the ability to turn on or off the prioritization of primary care data, and we can add more options and features to cater for more projects whilst ensuring backward compatibility. So rather than having 2 sizable notebooks, once the functions have been called, we have 2 lines of code. And we've actually extended the work to include the most recent lower layer super outputs area, the LSOA, as a key patient characteristic where by default we've turned off the prioritization of primary care records. And importantly, we're now able to identify ties and conflicts in records and retain the record date and source so that we can check which data sets and when our key patient characteristics are being sourced. So considering CCU 002 here, which included a population-wide cohort of 45 million individuals and an overall cut-off date of the 1st of January 2020, you can see where the information is being sourced from and how far we're looking back from baseline. The LSOA looks different due to not prioritizing primary care records. So whereas for CCU 18, where we're actually using individual sensor dates, and these are the dates of the delivery episodes, it's no surprise that almost all the key characteristics are recorded at time 0 at the delivery episode. So we've also coded further data checks, so we can look at the distribution of these key patient characteristics by quickly producing a table 1. Here we're also showing the index of multiple deprivation, which has been derived from the LSOA. We can look in more detail at the age distribution and the geographical distribution of the cohorts. And for CCU 18, we can complement this with the location of the more than 200 sites that contributed delivery data in England. And this all provides insight at a very early stage of the data curation process. And speaking generally, our aim is to have a suite of reusable data curation functions or common code that can be readily applied. So following this, we performed a series of quality assurance steps. So we've used the rules from CCU 002. This identifies less than 20 individuals in our well-defined cohort, and we'll look to extend this quality assurance work as we work on more projects. So moving on to covariates. So John will provide an overall summary of the covariates that have been generated in the two TREs, but I'm going to just describe the process for a single covariate. So considering the history of diabetes, again, we've used the CCU 002 definition, which included more than 1,800 codes across 3 terminologies. So taking our cohort of 770,000 women, using the GDPPR and the curated long HES-APC table, we can filter the records to before each individual's pregnancy start date and join these to our code list. And we find that this identifies 20,000 women who have records with codes matching our code list. And we can see how this varies by data source and coding terminology. Some individuals have records in multiple sources or terminologies. And we can also look by the codes themselves. So here we're showing the top 5 ordered by an individual's first or earliest matching code. We can see how these first events are distributed over time by data source and coding terminology. We can see that the DMD codes are only available more recently, as John alluded to earlier. And we can separate these out so we can look at the codes with the highest frequency for each data source and coding terminology. And we can also look at the distribution by key patient characteristics, such as sex, which is obviously not so informative for this cohort, and age group. And we've developed code to produce these automatically, these summaries and visualizations for each covariate in both the NHS Digital TRE and the SAIL data bank, as John will show, which hopefully provides a greater level of transparency and understanding when creating, deriving these covariates. So we can apply exactly the same methodology to create outcomes. It's the same set of functions that have been applied to covariates. Actually, for this project, we are creating 3 sets of outcomes, before the birth, at the birth, and post birth. So considering outcomes before the birth and taking gestational diabetes, this time we're looking forwards from the pregnancy start date up to the delivery date. And we find almost 60,000 individuals with an event during the pregnancy. We've automatically generated the data source and the code summaries. And you can see that this is largely being driven by 2 codes, one from the GDPPR and one from the HES-APC table. And again, we can look at the distribution over the weeks of gestation now by data source and codes within these, and the key patient characteristics. So finally, in terms of creating our exposure from the work already undertaken by CCU 13, this is a very straightforward process, just identifying the earliest date of confirmed COVID-19 infection for an individual from our curated COVID-19 trajectories table, and ascertaining whether this was accompanied by hospitalization both before and during the pregnancy. And John will summarise the outputs for those exposed alongside those from the SAIL data bank. So to summarise, the data curation pipeline results in 6 research-ready datasets that can be combined into a single table if desired. And following Ashley and Hoda's great work to visualise the layered data curation process in SAIL, we've started to develop a mirror board for the data curation process in NHS Digital, and I found it to be a useful tool to visualise the flow of data and the data dependencies. I'll now hand back to John to run through the data curation pipeline in SAIL and comparing the outputs from the 2 TREs. Thank you.
Thanks very much, Tom. I'll just start sharing the screen. Yeah. Can everyone see the slides again?
Yes.
Great. Thanks, Tom. So yeah, I'll now provide a higher level overview of the equivalent pipeline that we've developed in the SAIL data bank for Wales. So the SAIL pipeline for CCU 018 has been written in RStudio and utilizes the dbplyr and dplyr packages, which allow users to connect to and query databases using R syntax. These packages have similar syntax and strengths to the PySpark Python that is being used in the NHS Digital pipeline that Tom has just described, and so allows for the pipeline to be written in the same way and with the same inbuilt outputs, checks, and data visualizations, and also allowing for the same development of user-defined functions that Tom described. Some of the pipeline stages that Tom described are not required in SAIL. So, for example, the much smaller volumes of data mean that project-specific data snapshots are not really required here. Long format hospital episode coding already exists in SAIL, and so there's a reduced need for data curation steps. And finally, no equivalent skinny patient table code is produced in SAIL, and instead key patient characteristics are taken from the pre-provided e-cohorts available in SAIL. And so for this project, we're using the COVID-19 cohort 20, comprised of people alive as at the 1st of January 2020 in Wales. Outside of these differences, we're aiming for exactly the same code design and pipeline stages that we can see on the left-hand side of the slide here. So we'll be using the same code list that Tom described, establishing our project parameters in the same way, selecting our cohort, and then using the same code and syntax design for identifying covariates, outcomes, and exposures. So just by way of example, for covariates, the code is written in the exact same way and produces the same outputs. In SAIL, we have a cohort of 37,000. Again, we limit to records occurring prior to the pregnancy start date and join to our covariate code lists, looking in the GP records, hospital episodes, and in the daily dispensing data set. The same outputs are built into the pipeline, as Tom has already shown us from NHS Digital. So a summary of which sources cases are being identified from for each covariate, and also a code level summary. Similarly, there are plots to show how far back in time before the baseline date we are looking to identify covariates, and to show which sources they are being picked up in. So here, for example, we can see that in the case of depression, covariates have been picked up largely from primary care records, while both diabetes and hypertension have been picked up primarily from the medication codes, with a huge spike in the year that the medication data starts, which is a feature that we also saw in the NHS Digital data and pipeline. Again, similarly for outcomes, and in this particular example, outcomes during pregnancy. Again, we're looking at our cohort of 37,000 people, looking forward in time up to the delivery date for each individual, and looking in the primary care data and hospital episodes, producing our source summaries for each of the outcomes listed here. And again, we've got the more detailed code level summaries that allow us to scrutinize which codes are identifying the outcomes in our cohort. Again, we can see at what point in the course of the pregnancy these outcomes were identified. And again, we can see which sources they're being picked up in. So for gestational diabetes, we can see that cases are primarily picked up in primary care in the last 3 months of the pregnancy, whereas for gestational hypertension, cases are primarily picked up in the hospital episodes at or near the time of the delivery record. So the final output of the pipeline produces the exact same set of analysis tables as the NHS Digital pipeline, and the variables in each data set are created with the same names and formats to allow analysis code to be transferred between the DREs with minimal changes required. The aspiration here is really that researchers should just need to update their analysis code to connect to the specific databases and the analysis-ready datasets, but all other code should theoretically remain the same. Finally, moving on now to look at comparing the outputs from the two cohorts. Firstly, in terms of demographics, we can see that the cohorts identified in England and Wales have quite a similar age group profile, slightly younger for the Welsh cohort. Very similar profile in terms of the deprivation quintiles, going from 25% roughly in the most deprived down to 15% in the least deprived. And in terms of ethnicity, the English cohort has a higher proportion of Black and Asian ethnicity than the Welsh cohort. Now, looking at the number of pregnancies over the course of the study period, this plot shows the number of pregnancies per month for each cohort, and in orange indicates where a pregnancy is a woman's second pregnancy within the study period. The plot shows that the cohort covers the exact same time period due to the fact that we're cutting off at the same date, and also shows a very similar proportion of women with 2 pregnancies in the study period, roughly 1% in both TREs, reassuring us that the cohorts have been derived consistently across the 2 TREs. Similarly, this plot shows the number of pregnancies per month, but this time indicates the proportion that had COVID pre-pregnancy and during pregnancy. Just to highlight here that the x-axis shows the month of the estimated start date of the pregnancy, hence why we can see that there is COVID infection during pregnancy in the August 19 column. So these will be women who got COVID in the early months of the pandemic towards the end of their pregnancy. Here we can see that there are slightly higher rates of COVID exposure in the English cohort, 6.6% with COVID during pregnancy compared to 5% in Wales. Again, reassuring results in terms of how these data have been derived. In terms of COVID severity, again, we can see a similar profile in terms of the proportion of COVID cases that resulted in hospitalization within 28 days. Focusing in on those with COVID, in England, there are 60,000 COVID cases in the cohort, 5% of which were hospitalized within 28 days, and this compares to a rate of 4% for Wales. Moving on to look at some of the covariates and compare these across the 2 TREs. Here we have the composite cardiovascular disease covariates and the proportion of each cohort identified as having codes for these prior to their pregnancy start date. So these are quite healthy cohorts, so proportions here are very low, but reassuringly we see very similar proportions for each of the 4 cardiovascular disease groups in England and Wales. For other medical history covariates and for current medications, we again see very similar patterns and proportions for each cohort on the whole. However, here there are some comparisons that do show up some differences, particularly in the case of depression, where the codes that we have are identifying 27% of the cohort in Wales compared to just 20% in England, which would warrant further investigation. And again, this is where the inbuilt outputs that are built in as part of the pipeline can be very useful, so that we can focus on those depression codes, identify which codes are generating the hits in the cohort, and scrutinize these to see if there's any amendments that need to be made to the code list. In closing, all of the work we've presented here is very much still a work in progress, and the pipeline we've developed has been based on generalizing and streamlining pre-existing data management and curation code from within the TREs. We want to keep streamlining this code on future projects by building a suite of reusable functions like the skinny table function that Tom described earlier. We think that this work will be of most value to new TRE users and projects with similar designs, but we do also hope that it will provide useful guidance for more bespoke projects. And ultimately, we hope that this work will help to reduce the length of time taken to create analysis datasets, and will provide efficient and consistent dataset construction and practical, easy use of the data. Just to close by saying thank you for listening.
And can I extend my thanks as well to the BHF Data Science Centre team, Angela Wood. We've obviously worked closely with Elena on CCU 18, and more recently with Louisa, Rachel and the Bristol team, who are also embarking on a pregnancy-related project. The CCU 002 team, Sam, Spencer, Rochelle, Benicia, the CCU 13 team, Spiros, Chris and Johan, many others in the consortium, the Data Wrangler team, Sale Data Bank colleagues, Ashley, Hoda and Fatima, and also the NHS Digital Output Checkers, Lisa and